Hi everyone, I am Dr. Harish, an ENT surgeon. Today we will be talking about the important topic of otosclerosis from the point of view of MBBS Part 1, that is ENT. MBBS Final Part 1, that is ENT. Okay. So today we'll be discussing about otosclerosis. So if you break up this into two parts, oto means ear and sclerosis means abnormal hardening of the body tissue. So there is abnormal hardening where there should not be hard tissue, there is abnormal hardening happening. Okay. What are the questions asked from this topic in MBBS Final Part 1? So this is an important topic, and the questions asked in the previous years were discuss the etiology, clinical features, investigations and treatment of otosclerosis. So it's giving 2 marks for etiology, 2 marks for clinical features, 3 marks for investigations and 3 marks for treatment. Another question is management of otosclerosis for 5 marks. The shorts for 2 marks are differential diagnosis, DD of otosclerosis, Carhart knots and stapedectomy. By the end of this presentation, I hope that you will have enough grip to write these answers quite easily and also have enough grip on the concept of this topic. Now, coming to the otosclerosis. Now, what is so special about otosclerosis? Otosclerosis is the most common cause of bilateral progressive conductive hearing loss in adults. So, why otosclerosis is important either in MBBS Final Part 1 or in NEET PG is it is the most common cause of bilateral. So, both the ears are affected and it's a progressive condition. The condition starts slowly, insidious onset, and goes on increasing as the time passes. So it is a bilateral progressive. It's a conductive hearing loss. It is predominantly a conductive hearing loss. When we are talking about the definition, it is a conductive hearing loss. Though there are some sensorineural instances which are rare. Okay, hearing loss in adults. Okay. Now otosclerosis, the other name is otospongiosis. Why did we use the word otospongiosis? Otospongiosis refers to the active stage of the disease. When the disease starts, it is active, and as the time goes on, it becomes into inactive stage or the final stage. So it refers to the active stage of the disease with vascular spaces with highly cellular fibrous tissue. So because there is lot of fibrous tissue, highly cellular fibrous tissue, we refer to as a spongy bone. The new bone that is forming is called the spongy bone. So it is referred to as otospongiosis initially. Later on it is called otosclerosis. Both are, we can use it interchangeably, but to be specific, what do we mean when we are using the word otospongiosis? We are meaning that the new spongy bone is forming. What is otosclerosis? Otosclerosis refers to the final stage of the disease consisting of highly mineralized bone with a mosaic appearance. So it is the final stage of the disease, that is initially the spongy bone is forming, and there is remodeling. Remodeling means there is formation of bone and there is also resorption of bone. Okay, and finally after many decades you will have a highly mineralized dense bone. Okay, highly mineralized dense bone where you call it otosclerosis. Okay, fine. Now, before we explain about this topic, let us have a little bit of relevant anatomy so that you know the various like basic relevant anatomy, so that you know from where to start. So this is where the whole disease process is happening, right? So this is the bony labyrinth. So this is a complicated topic, so I wanted to have a few slides. So bony labyrinth parts, the parts of the bony labyrinth are the 3 semicircular canals. This is the first semicircular canal, this is the second semicircular canal, and this is the third semicircular canal. The part in the middle, this part in the middle is called the vestibule, and the part in front is the cochlea. The cochlea is the bony cochlea. Okay, bony cochlea. Now to be a little bit more specific, this bony cochlea, if we have a cross section of this bony cochlea, you will find that it has three compartments, 1, 2, 3. So the middle part is called the scala media. The middle part is called the scala media, which is also the cochlear duct. Cochlear duct, also called the cochlear duct. It is also the membranous cochlea. Okay, membranous cochlea. Okay, on top you have, this is the part of the bony cochlea, that is the scala vestibuli. Underneath it you have the scala tympani. Let us not go into the intricate anatomy of this. When we talk about the anatomy of the cochlea, we will be describing about that in detail. Okay, so bony anatomy, relevant anatomy of the bony labyrinth is basically you have the three semicircular canals, 1, 2, 3 semicircular canals. The part in the middle is the vestibule, the part in front of it is the cochlea. So always remember that the cochlea is anterior and the semicircular canals are posterior. So the anterior part is the cochlea. Okay, now coming to the membranous labyrinth. Okay, membranous labyrinth. Membranous labyrinth is also having the same parts, except that it is a little bit different. So the three semicircular canals are the same. Okay, so one is anterior, one is the posterior, one is the lateral. Okay, and the membranous cochlea is also the same. Okay, so this is the same thing, membranous cochlea. So this, what they call it, the membranous labyrinth, is a closed tube or a closed sac. Okay, it has no openings. It has no openings, but the bony labyrinth is connected, is having openings, like it is having the vestibular aqueduct and the cochlear aqueduct. Now let us not go into that too much. Okay, so you have the three semicircular canals, and you have the membranous cochlea. Now we are using the word membranous cochlea. It's also called the scala media. Okay. In addition, you are having three parts. That is, this part here, where all the three semicircular canals are opening into, is the utricle. Okay, utricle is connected to the saccule. So the saccule is another part of the membranous cochlea, and it is connected to utricle by the utriculosaccular duct. This is the utricular duct, which is the saccular duct joining to form the endolymphatic duct, which is continuing to form the endolymphatic sac. So you have the utricle, you have the saccule, and the endolymphatic duct and sac. So this is the saccule is connected to the membranous cochlea by this opening that is called the ductus reunions. Okay, so this is the basic anatomy of the membranous labyrinth. Now we have to understand that the membranous cochlea is enclosed in the bony labyrinth. So here you can see this above part, this red colored one is the bony labyrinth, and this green colored one is the membranous labyrinth. So both of them are same in shape, but the bony labyrinth is bigger in size. So these are the various parts of the membranous and bony labyrinth. Now coming to our topic today, that is otosclerosis. Otosclerosis is defined as a hereditary. So there is a hereditary component, localized. It is localized to the bony labyrinth. It is not present all over the body. Inside the bony labyrinth also, it is localized to a very certain part, very particular part. It is characterized by alternating phases of bone resorption and bone formation. So what is the definition? Otosclerosis is a hereditary localized disease of the bony labyrinth characterized by alternating phases of bone resorption and bone formation. Now, the most important thing is pathogenesis. So if you know about this pathogenesis, what happens in pathogenesis, you will come to know everything about otosclerosis. What are the clinical features? What is the treatment? What is the investigations you want to do? What is the differential diagnosis? Everything you can explain by the pathogenesis. So step by step we are coming. So bony labyrinth, as we have already talked about, is made of dense enchondral bone. But in this dense enchondral bone, there are cartilage rests are present in this enchondral bone, mostly in the area of the fistula antefenestrum area in both ears. So we did not talk about the fistula antefenestrum in the anatomy. Now let us talk about this. This blue area that I want you guys to focus on is called the fistula antefenestrum. Fistula, it is not fistula. Fistula antefenestrum. So this is a part, the blue area that I have marked here is just anterior fenestrum oval window. So it is just anterior to the oval window. That is where you have cartilage rests. In this dense enchondral bone, there are some cartilage rests. So, bone labyrinth is made of dense endochondral bone. Within this dense endochondral bone, mostly in the area or most of the time in the area of fistula antefenestrum, you have cartilage rests. Now, where are they? They are present in both the labyrinths of both the ears. Now, this is something that we usually we overlook. That this is a bilateral disease. This is a bilateral disease. It is present in both the ears. Okay, so this cartilage rests are present in the fistula antefenestrum in both the ears. Because of various factors, these cartilage rests get activated by various factors to form new spongy bone. Now, this is where the pathogenesis is starting. The cartilage rests are supposed to be inactive, but because of various factors, these start to form new spongy bone. This new spongy bone, because it is very close to the stapes footplate, starts to grow over the stapes footplate. So it starts growing onto the stapes footplate, causing the stapes footplate, leading to the fixation of the stapes footplate to the oval window. Because this is such a slow process, so the process is very slow and insidiously progressing process which is spanning over many years. So there is this formation of the new spongy bone which is going on to the stapes footplate and finally causing stapes footplate to get fixed onto the oval window. So there is fixation of the stapes footplate to the oval window. What is it supposed to do? It is supposed to be mobile, right? When the sound comes and touches the tympanic membrane, it passes through the malleus, incus and stapes, and from there it goes to the inner ear, scala media, scala tympani, scala vestibula and scala tympani. This is the physiology of hearing. So it is supposed to be easily mobile, right? But now it is getting fixed. It doesn't get fixed all of a sudden. It is a slowly progressive kind of a disease. Finally, after many decades, the final dense ankylosis of the stapes footplate to the oval window occurs. So over a period of many years, so there is dense ankylosis of the stapes footplate to the oval window. This results in conductive deafness. So as it is quite obvious, there are three types of deafness, right? One is conductive, one is sensory, one is neural. Conductive is when there is problem in the tympanic membrane, or if there is something in the external auditory canal, or if there is any problem with the ossicles. Okay, sensory is when there is a problem with the cochlea, and neural is when we have a problem with the 8th nerve. Okay, cochlear nerve. Okay, so now because the disease is very localized and it's only affecting the stapes footplate, so we have conductive hearing loss. So what are the features of this conductive hearing? One is bilateral. As I said, it is affecting both the ears. Then it is painless. So there is no question of pain at all. So it is a painless kind of hearing loss, and it is insidious onset and slowly progressive. So these are the four features of conductive hearing loss, which help you to differentiate this kind of deafness, that is the deafness caused by otosclerosis, from other deafnesses. Okay. Now coming to etiologies. Now this is what the question is asking, right? What are the etiologies? Write a little bit about pathogenesis. Write pathogenesis compulsorily. If it's possible, write draw the line diagram that I have shown you here. So these are the line diagrams. These line diagrams, when you draw these line diagrams, they come to know that you know about this topic, what you are trying to talk. At least one or two line diagrams. Okay. Then you write this pathogenesis, this flow chart. This flow chart will solidify the impression of your question paper, of your answer paper, that you know what you are talking about. Now coming to etiologies. Etiologies, age of onset. Age of onset. Now okay, we'll come to that in clinical features. Okay. Age of onset, the patient is usually in the 20s or in the 30s, right? 30s or 20s. So it is less than 10 years, doesn't happen. Greater than 40 years, very rare. So usually the patient presents in their 20s and 30s. Okay. Now racial. Now white races are affected more than Negroes. Okay. And Indians are affected more than Chinese and Japanese. So this is the incidence. prevalence. Prevalence of this disease is when they mark it out in the world. It is more in Indians compared to Chinese. It is more in whites compared to Negroes. Whites, you also use the word Caucasian races. White races are called Caucasian races. So it's more common in Caucasian races. Third one, sex or hormonal. It is more common in females. With a ratio of 2:1. Almost double in females. But in India, we do not see this female predilection. It is more common in males. That is what is the textbook description. But for all general purposes, it is understood that it occurs more common in females in the ratio of 2:1. When it is occurring more common in females, it means that there is some hormonal factor involved. Then also we see that the disease progresses rapidly during pregnancy and during menopause. So there is some hormonal factor causing the rapid progression of the disease, that is otosclerosis. So there is some hormonal etiology. Hereditary. Coming to hereditary, 50% of the cases are hereditary. So you will see this. To give you one clinical picture, you will see a young female in her 20s and 30s, okay, who will come to you saying that I'm having bilateral mild to moderate hearing loss. I'm not able to hear well. I'm having hard of hearing, and that my mother also has suffered from the same problem. That is, it is hereditary, and the disease increased after giving birth to my first child. So in pregnancy, the disease increased. Okay. So this is how the clinical picture of the patient, right? So hereditary, 50% of the cases are hereditary. Rest of them are sporadic. Okay. This hereditary, it is called the autosomal dominant inheritance. Autosomal dominant inheritance. We can see this autosomal dominant inheritance in hereditary. Okay. Now coming to the other one, congenital. Congenital etiology. Why congenital? Because there are congenital cartilage cell rests in the enchondral bone, which are getting activated by various factors like autoimmune, like we will come to that next, which are getting activated by various factors to form new spongy bone, which finally goes and attaches the staples to the oval window. Okay, autoimmune. Now coming to the sixth etiological factor, autoimmune. So this is, we say it's autoimmune because there are some antibodies that we have found against type 2 collagen. Okay, so because of this, there is an autoimmunity factor to this disease. Infection. It is described that after measles virus infection, the disease increases, or the disease is precipitated. Trauma. Now coming to trauma, they say that the disease has got precipitated, or the disease, we came to know about the disease, or we started getting the symptoms of the disease after a major operation or some kind of road traffic accident or trauma. You went through some traumatic thing, and the disease got precipitated. Okay, then what is osteogenesis imperfecta? Osteogenesis imperfecta is a disease, is a hereditary disease, characterized by a triad of otosclerosis. So you will see otosclerosis here, you will see blue sclera, and osteogenesis imperfecta. Osteogenesis imperfecta. What is osteogenesis imperfecta? Here, this is the healthy bone. So here you can see the spongy bone defined by the small brownish dots, and the rest of it is called the compact bone. In osteogenesis imperfecta, the spongy bone increases in comparison to the compact bone. The spongy bone increases, compact bone decreases, causing the bones to break. So that is called brittle bones. So if you have a triad of osteogenesis imperfecta, that is multiple fractures, you can see the blue sclera. Because why is there blue sclera in these patients? Because there is some defect of the collagen. So collagen is needed for making this sclera. So you can see the blue sclera. And otospongiosis, that what is the basic pathophysiology of our disease is there is spongy bone formation. So the same thing is happening in osteogenesis imperfecta. When the triad of this otosclerosis, blue sclera and osteogenesis imperfecta, when we find this triad, it is called the Van der Rohe syndrome.